right side, this is left side testis. From here to the epididymis, the vas is carrying the sperm. So sperm is produced from the testis, it is being carried by the vas like this. For a long distance, it runs in the retroperitoneum, the vas is going very long distance. And it is going to enter the prostate. This is going to enter the prostate. This is prostate. It's going to enter the prostate. Before entering the prostate, it is joined with seminal vesicles. This is seminal vesicles. What is the function of this seminal vesicle? So please understand the normal anatomy I'm discussing. That is very important for your exams. This is seminal vesicles. What is the use of the seminal vesicles? A sperm which is traveling very long distance from here, very tired. It is very tired. When it is coming near here, it needs energy. That energy fructose is given by seminal vesicles. That is given by seminal vesicles. So vas now joins with seminal vesicles, and this is seminal ducts. They join together to form what? What is this known as hereafter? What is this known as? Seminal vesicles and vas join together to form ejaculatory duct. They form ejaculatory duct. And from here it enters the prostatic urethra, membranous urethra, bulbar urethra, penile urethra, and come out of the penis. So this is the normal pathway of sperm. Normal pathway of sperm. So now anything which happens in men are usually bilateral. Please remember, any pathology which is happening in these guys are usually bilateral. Now let us assume a patient comes to you with a male patient comes to you with infertility. What test you will immediately advise him? You will advise him semen count, which you will be reading more detail in gynecology. Semen analysis will be done now. Semen analysis is done. So now immediately you are sending the patient for semen analysis. So the features which you can get in semen analysis are, so the semen analysis will show azoospermia, no sperm at all, zero sperm. In the semen, there is no sperm at all. So there is no sperm, zero sperm. What is the reason? Can you tell me? A sperm is absent in semen analysis. This may be due to, number one, ejaculatory duct obstruction. So I'm telling everything is bilateral. Ejaculatory duct obstruction is one reason. Another reason is testicular failure. Another reason is vas obstruction bilaterally. So when a patient comes to you with azoospermia, no sperm at all in the analysis, the reasons may be either ejaculatory duct is obstructed here, or the vas is obstructed, or the testis is not at all functioning. So these are the causes of azoosperm. Or a patient comes to you with a decreased volume, but there are sperm present. Please remember, sperm is present, but the volume is less. So volume is less. The reasons may be, number one, it can be due to retrograde ejaculation, which we have already discussed. It can be due to retrograde ejaculation in case of bilateral lumbar sympathectomy. In case of post-TURP, the patient develops internal urethral sphincter. Some reason the internal urethral sphincter is not working properly, so the sperm instead of coming anterior, it goes retrograde. That is one reason. Another reason is there is obstruction of vas or ejaculatory duct or seminal vesicles on one side, unilateral. There is obstruction of any one of these on one side. So one side sperm is not coming to one, another side only the sperm is coming. So the only question asked in this from urology part of view is, a patient is coming to you, let us assume he is Mr. Somu coming to you and giving in a bowl sperm for analysis, semen for analysis. You are analyzing this semen, he is having infertility, you are analyzing his semen, on semen analysis, his sperm is normal, sperm count is normal. But there is one important thing, there is a decreased fructose. There is decreased fructose in the sperm. What is your diagnosis in this case? So what is the problem? Why Somu has sperm count normal, but fructose content is less. It means there is obstruction of seminal vesicle. There is seminal vesicle obstruction, which is producing the fructose. Seminal vesicle gets obstructed. So seminal vesicle obstruction, ejaculatory duct obstruction, vas obstruction. I'm telling you, many places obstruction. What may be the common cause in India? The most common cause of these type of obstructions is tuberculosis, same like fallopian tube obstruction in females. The most common cause of this cases may be tuberculosis. So obstruction of these ducts can be due to tuberculosis. We must rule out TB also. And investigation of choice to look for ejaculatory duct obstruction, answer is transrectal ultrasound. Another investigation which you can do is vasography. Through the vas, you have to push the contrast and see. But anyhow, transrectal ultrasound is enough. That is non-invasive and superior to vasography. So the investigation of choice is transrectal ultrasound is superior to vasography. And final test in an infertility will be what? That will be the last test, whether this fellow's sperm will be useful or not, or will he produce sperm or not. The final test will be testicular biopsy. So the final test in these cases will be testicular biopsy, and it is a very important topic from your pathology books you have to read. So the last test is testicular biopsy we have to take and see for whether any seminiferous tubule functioning is present or not. That should be the last test. Please don't forget it. Let me show you the images from this chapter now. So what are the McNeil zones? Transition zone is a central zone and peripheral zone. So transition zone produces BPH, peripheral zone produces cancer. Please don't forget. And similarly, lobes are anterior lobe. This green color is anterior lobe. This is middle or medial lobe, and posterior lobe and lateral lobe. From the middle or medial lobe only arises BPH. From the posterior lobe arises cancer. So BMP, CPP. Please don't forget all those things. So what is the most common stone in prostate? Calcium phosphate, PP. All these points we have discussed. Please don't forget the anatomy. This picture shows you internal urethral sphincter. This picture shows you external urethral sphincter. Injury of internal urethral sphincter causes retrograde ejaculation. External urethral sphincter causes incontinence. What's the complication? Okay. And this is the picture showing you the verumentanum. The distal limit of TURP is verumentanum. Please don't forget. The distal limit of TURP is verumentanum. This is the picture based on Balian law. So this is 2 is retropubic. You go and remove the prostate of Millen. 3 is transvesical prostatectomy of Freyers. Perineal prostatectomy of Young. Okay. All these are various methods of prostatectomy. So you can see a TURP procedure is going on. This is showing you a verumentanum. Verumentanum is shown here. So the prominent verumentanum is shown here. So this is a 3-lumen Foley catheter for irrigation. Okay, 3-lumen Foley catheter, 18 French will be used. So please don't forget the various complications I told you, and don't forget the newer operations, tulip and collab. So transurethral ultrasound guided laser-induced prostatectomy and chromium laser enucleation of prostate, collab. So cancer prostate we have discussed various points. So these are the 2 methods of biopsy. So transrectal biopsy of prostate and transperineal template biopsy. 36 biopsy is possible with this method. Okay, so various T staging I told you, T2A is involving one lobe, T2B is involving both lobes. So T1, T2A, T2B we can do prostatectomy. T3, T4 we do only androgen ablation. Okay, we don't do surgery. So various androgen ablation methods we have discussed, and this is a Gleason scoring system. So total new scoring is varies from up to 10 it has. So under the male infertility factor, I told you the various factors. Please don't forget, if there is a seminal vesicle obstruction, there will be decreased fructose content. Seminal vesicle obstruction will have decreased fructose content. Please don't forget it. Okay? So these are the points I want you to remember from the prostate and seminal vesicle chapters. So we'll stop here and we'll move to the next topic. So next we are going to discuss on urethra and penis. Okay, we're going to discuss on urethra and penis. So this is a very small chapter, but there are certain interesting and MCQ points. MCQ points are there. So let us first start with one by one the diseases. Number one, hypospadias. So I'm going to discuss around 5 to 6 diseases in this chapter. Hypospadias. Hypospadias, the first point you should not forget is this is the most common congenital anomaly of lower urinary system. This is the most common congenital anomaly of lower urinary system, especially of penis. Of lower urinary system. Okay, especially of urethra is the most common congenital anomaly. It is seen in 1 in 250 people. So what is actually happening in this? So please see the picture. This is urethra. This is corpus spongiosum. So this is glans penis. Usually the urethra opens in the center of the glans penis. What happens in this case is, instead of it opening here, it opens downwards like this. So this is known as ventral opening of urethra. Please don't forget, everything is important. Under surface of penis is known as ventral part of penis. The first step in hypospadias is there is ventral opening of urethra. Number one. And there is a hood of skin on the upper part. What is it known as? It is known as dorsal hood. The hypospadias is characterized by the following anomalies. There is dorsal hood, ventral opening of urethra, and there is one cord-like structure on the undersurface. What is it? This is ventral cardi. Ventral cardi. So what is hypospadias? Hypospadias is made up of the following components. So the ventral opening of urethra, so the urine will be passed on the patient himself. When he is passing the urine on standing position, urine will fall on himself. So ventral opening of urethra, dorsal hood, ventral opening of urethra, and ventral cardi are the three important components seen in hypospadias. Other associated features may be cryptorchidism, undescended testis. Cryptorchidism and indirect inguinal cornea may be associated. Cryptorchidism is seen in these patients in 8% of these patients. Will have cryptorchidism. Indirect inguinal cornea is also associated in these cases. Okay, so please don't forget, hypospadias is ventral opening of urethra. And the types of hypospadias are, it can open at the level of gland itself, it is known as glandular hypospadias. It can open in the corona gland, that is known as coronal type of hypospadias. It can open in the shaft under surface, that is known as penile. Or it can open in the perineum, perineal. Perineal hypospadias will have the two scrotum split and the opening will be seen under the scrotum. So perineal, there are many types like this, and the glandular type is most common type, and no treatment needed for glandular type. So glandular type, nothing to let them live with the glandular, nothing will happen. So why should you worry about these hypospadias? The problem with hypospadias is the penis will be bent like this downwards. So what will happen? They will have difficulty in sexual intercourse in future. And not only that, the sperm will come back and it will not go inside the vagina in future. So there will be sperm coming out from the vagina will be there, sexual problems will be there, and they will have difficulty in maturation. Thinking all these in mind, we should take them up for surgery by the age group of which age group surgery is done. Surgery is done between 6 months to 1 year. Very interesting. For a future problem, the surgery is done at 6 months to 1 year itself. Now itself it is done. The ideal age of surgery is 6 months to 1 year. Okay. There are many types of surgeries done, but whatever it is, before knowing the surgeries, please remember, circumcision is contraindicated in these guys. Circumcision is contraindicated for them. Because only with the foreskin we will reconstruct urethra. Therefore, circumcision should not be done. Okay. There are many methods of operation, and the old method of operation is Dennis-Brown operation. Dennis-Brown operation is the old operation, which is two-stage surgery. It is a two-stage surgery done in those days. So two-stage operation is known as Dennis-Brown operation was done in those days. But now we are not doing this operation Dennis-Brown. Now we are doing MACP procedure. MACP. Single stage operation. MACP is a single stage operation in which we do meatal advancement, granuloplasty incorporation. So this question is a repeat question. What is done in MACP? So in MACP, the question can come as order-based question. So what is the sequence we do repair? The first repair is done as arthroplasty. Arthroplasty. Arthroplasty means first thing is we will make the penis straight. How will we make the penis straight? First procedure done is making the penile straight. So that is known as arthroplasty. We will cut the cardi. We will make it by cutting the cardi. Then second is urethroplasty. We reconstruct the urethra. From there it is ending. From there we have to reconstruct the urethra. Third is glandsplasty. Glandsplasty. Then meatoplasty. So this question has been asked in exam. That is why I am discussing. And if there is a scrotal split, we have to do scrotoplasty. Okay, we have to do scrotoplasty. Finally, last step only we have to use the skin reconstruction. For example, circumcision if needed, you will do only in this step. So arthroplasty, first step is, please understand, you will not forget. First step is you should make the penis straight. First cut the cardi. Now the urethra is ending here. Reconstruct the urethra. Second step is urethroplasty. After reconstructing, the glands needs to be sharpened. So the glandsplasty. So first three you won't forget. Arthroplasty, penis straightening, urethra reconstructing, glands reconstructing. Now this is the meatus. So the meatus should be external urethral meatus should be reconstructed, and the scrotum, if there is any anomaly, scrotum should be reconstructed. Finally, you should reconstruct the skin. This question is once asked in James. Sequence-based question can come in future. So the order of reconstruction of penis. Okay, please don't forget this point. Arthroplasty is penile centering, urethroplasty, glandsplasty. So arthro, make it straight, reconstruct urethra, then make the glands penis perfect. Then only you go for meatoplasty, scrotoplasty, or skin reconstruction. This is known as hypospadias. Opposite to this, very rare condition is there. What is it? Epispadias. The rare condition is epispadias. What is there? What is the problem in epispadias? Very straightforward question. The urethra is opening like this. To which surface? Urethra opens on the dorsal surface of penis. It opens towards the dorsal surface. So when the patient passes urine in a standing position, it will flow like a fountain. Like this, it will flow like a fountain. So dorsal opening of urethra is known as epispadias. So dorsal opening of urethra is epispadias. Okay, epispadias is dorsal opening of urethra in which the urine will come out like a fountain from up. Most worst anomaly, but luckily this is a rare anomaly. It is rare and it is commonly associated with what? Most commonly associated with ectopia vesica, which we already discussed. So most commonly associated with ectopia vesica, rare anomaly, epispadias. Now coming to phimosis, one of the common problems in the community is phimosis. So phimosis is nothing but, what is phimosis? This is a penile skin. Okay, this is penile skin. This is glans penis and the inner part of the penis. So if you are unable to retract this prepuce backwards, it is known as phimosis. If you are unable to retract the prepuce backwards, it is known as phimosis. If you are unable to retract the prepuce backwards, what will happen? There will be collection of, what is this green color what I am drawing here? That is known as smegma. There will be collection of smegma in the coronal area. Coronal area smegma will be collected, which is produced from Tyson's glands. It is produced from Tyson's glands. Smegma will be produced. That will be collected underneath. That will cause carcinogenesis in future. So therefore, phimosis is a pre-malignant problem. It is a pre-malignant problem. So please remember, it can be of two types. Congenital phimosis, which can be seen due to physiological adhesions up to 6 years, you can get this. So congenital phimosis is up to 6 years. The patients may have some physiological adhesions. Up to 6 years, the adhesions may be present. So no compulsory to operate before 6 years. In congenital phimosis, we can operate after 6 years also. And acquired, what are the acquired causes of phimosis? Acquired causes of phimosis are inflammation. Yes, inflammation. Due to some inflammation may happen. Diabetes causing balanitis, or balanitis xerotica obliterans, or cancer. Like that, many other acquired causes are there, including trauma. Like that, many causes are there. Acquired causes of phimosis will be there. The inability to retract the prepuce back will cause phimosis. What will be the problem? So the patient will get smegma collected and it will cause future carcinogenesis, and during sexual intercourse they may have tear of the prepucial skin may also happen. Therefore, congenital cases we can wait up to 5 to 6 years. No need to operate before 5 to 6 years. We can wait up to 5 to 6 years. But for acquired cases, surgery is done. Surgery is done. Okay. But in babies, less than 1 year babies, if they are having severe ballooning of prepuce, why there is ballooning of prepuce? The prepucial opening is very small, even the urine cannot come out. Severe ballooning of prepucial region is seen because of tight penile. Penile opening is good, but the prepucial adhesion is very tight. The urine cannot come out and the baby is crying. So such cases we can operate. We can operate for those babies. The tight obstruction of urination due to severe tight prepucial thickening we can operate. Otherwise, if there is no such symptoms, we can wait for 5 to 6 years. And for less than 1 year, there is one method of circumcision known as Hollister device. I will show you the device in images. Hollister device, also known as plastibal device, is available. Just put that device, cut the skin, no suturing needed. Hollister or plastibal device is done for less than 1 year only, not for others. Usually after 3 to 4 days, the device can be removed out. It will be perfectly fixed at the tip of the penis. Plastibal or Hollister device. So what are the conventional methods? Conventional methods of circumcision are, 2 methods are there. Number 1, dorsal slit method. Another is guillotine method. Guillotine method, we pull the excess skin and cut it like that. If you pull the excess skin and cut it like a horizontally, be careful, you should not go and cut the glands. So guillotine method and dorsal slit method are the 2 conventional methods of circumcision. In dorsal slit method is a safer method. Safer method. Guillotine method, be careful, but usually guillotine method is what followed by Muslims during the infantile circumcision. They usually follow the guillotine method only. Okay, please don't forget that method. Guillotine method is usually followed by Muslim people in practice. There are now types of circumcision. So types of circumcision can be neonatal circumcision, infantile circumcision, adult circumcision. So what is it? Neonatal means at birth. Circumcision is done at birth due to religious background. Which religion they do circumcision at birth? Jews. Infantile circumcision within 1 year. Who do circumcision in less than 1 year? Usually done by Muslims. So many people, they voluntarily go for circumcision and do in prepubertal or in the postpubertal or an adult age. So that is adult circumcision. So interesting point here is, while Jews do neonatal circumcision, there is no smegma gets collected and there is 100% protective of cancer penis. 100% protective of cancer penis. So they never develop cancer penis in Jews. Muslims, there is decreased incidence of cancer penis. But in adults, there is no relation with cancer penis. No relation. So it does not decrease the risk. The risk of developing a cancer, if it has to happen, has already happened because of smegma. Hereafter, there is no use. So what are the uses of circumcision means? In neonatal circumcision, 100% protected. Infantile circumcision, Muslims have decreased incidence of cancer penis. In learning all this thing, even if you go and do circumcision tomorrow, it is going to be no use for cancer purpose. For cancer purpose, there is not going to be any use. Okay, please remember this. Okay, now coming to paraphimosis. So please don't forget the device. I will show you plastibal or Hollister device in images. So next is paraphimosis. Paraphimosis is a condition in which this is glans penis. The prepucial skin has come back and it has been locked out like this. And it is locked like this. So the prepucial skin is not going back to the normal position. It has come back and it is not going to the normal position. This is paraphimosis. Retracted prepuce. Retracted prepucial skin usually follows an aggressive sexual act. So the skin has come back now, becomes edematous and painful. The patient will come to you with a severe pain and edema. You have to keep cold ice packs on it. Cold ice packs are kept on it. And we can put small needle puncture into the dilated part and try to manually, applying lignocaine jelly, manually try to pull back the skin. Manually try to pull back the skin and advise him circumcision at the earliest. So circumcision should be done afterwards. So after reducing the prepucial skin, advise him to go for circumcision. By chance, by keeping ice pack, by putting multiple holes, it is not coming back. What I will do then? What is the treatment for such cases whom we cannot reduce by conservative methods? Treatment is dorsal slit only will be done. You will make a dorsal slit in the prepuce and reduce it. We don't do circumcision now because the skin is edematous. So just do dorsal slit alone and ask him to come for circumcision later. So this is one other problem, paraphimosis. Please don't forget paraphimosis. The next comes another disease, that is Peyronie's disease. Peyronie's disease. Peyronie's disease is a fibrosing condition. Peyronie's disease is a fibrosing condition associated with Dupuytren's contracture, retroperitoneal fibrosis, Riedl's thyroiditis, All these are fibrosing conditions in your body. So dupuytren's contracture, retrograde fibrosis, riddles. Similar fibrosing condition is Peyronie's disease of penis. In this condition, what happens is the penis gets curved like this. The penis gets curved like this. That is painful, persistent erection with deformity of penis happens. So painful, persistent erection with deformity of the penis happens. Usually the penis turns to which direction? Downwards or upwards? Usually the penis turns dorsally. So please don't forget what is dorsum of penis. Upper part of penis is dorsal. That is usually a dorsal curvature seen. The patient comes to you usually with a painful, persistent erection. With a deformity, the patient comes to you and he is usually a middle-aged man. Middle-aged men usually get this. It's usually seen in middle-aged men. So when these patient comes to you, when you take an X-ray itself, the X-ray itself will show what? Calcified fibrous plaques in the penis. So the penis will be seen on X-ray. Calcified penis is seen on X-ray. So calcified fibrous plaques are seen on X-ray itself, and we must advise them to undergo one wedge resection like this. Make a wedge resection like this and make the penis straight like this. What is this procedure known as? This procedure is Nesbitt procedure. We advise them to undergo Nesbitt procedure. So Peyronie's, this is a fibrosing condition of the penis in which fibrous plaques deposit on the penis and therefore they become painful, persistent, erected with a deformity. When you take X-ray, it will show calcified plaques. Such patients will need penis straightening operation known as Nesbitt procedure. Nesbitt procedure. So when you discuss about Peyronie's disease, I have seen many times the students getting confused with priapism. So don't get confused Peyronie's and priapism. Peyronie's is not a dangerous condition. This is nothing to worry. They will become normal or they will not have much suffering. But priapism is more suffering problem. It is a painful erection of penis. Following a sexual activity, the penis becomes erected and not becomes a normal shape after ejaculation also. Painful erected penis is known as priapism. Painful erected penis is known as priapism. It is derived from the name of a god, Priapus. Priapus god, a person who had a very long penis and he is known as god of fertility. He used to have such a long penis and when you pray, these guys, you will get babies. Like that, it is an old belief. So Priapus god is the name from which priapism is derived. So to understand priapism, you should understand the anatomy of penis. This is corpus, this is corpus spongiosum. So this is corpus spongiosum. One corpus spongiosum is present in the center which is carrying the urethra. On either side of the corpus spongiosum, what we have? We have two corpora cavernosum. These are known as corpora cavernosum. Okay. This is known as corpora cavernosum. So there is one corpus spongiosum and two corpus cavernosum. So what is actually happening in erection is the blood vessels flow into the arteries flow the blood into the penis like this. So as the blood enters the penis becomes engorged and erected until ejaculation. After ejaculation is completed, the blood will go back through the veins like this and the erection falls down. This is a normal mechanism. But in priapism, there are two problems. One is high flow priapism, in which I told you the arterial blood flow. The arterial blood flow, the blood entering is coming enormous amount. That is increased arterial blood flow. Increased arterial blood flow. That is known as high flow priapism. There is draining of blood to the veins, but there is increased arterial flow. It is seen in conditions like spinal cord injury, spinal shock, spinal cord injury. Where else? It is seen in retroperitoneal injuries. It is in retroperitoneal injuries or in cases of papaverine injection. Some people used to put papaverine in the penis for a persistent erection. For persistent erection, papaverine injection being used. So these cases will have high flow priapism. Nothing to worry, no need to worry about this. They usually resolve. When you do analysis, arterial blood gas analysis of the blood taken from the penis it will show you increased oxygen content. So the increased oxygen content is seen in the penile blood flow. So this is not much dangerous. So next one which is going to be dangerous is low flow priapism, very commonly seen in sickle cell anemia, leukemia, lymphoma. Sickle cell anemia, leukemia, lymphoma, what happens? The venous return of blood is obstructed like this. So though the blood flowing inside is through the artery is very slow, the venous outflow is obstructed. So what happens? The penis becomes strangulated, like a venous strangulation happens. The engorgement of the penis is going like a venous strangulation happens. So who will get this low flow priapism? Dangerous condition, sickle cell anemia, leukemia and lymphoma. So when you do ABG analysis, it will show you decreased oxygen content. So there is decreased oxygen content in low flow priapism. Urgent treatment needed for these cases. So low flow priapism need urgent treatment. So I'm not discussing anymore about high flow priapism. It will usually resolve. So low flow priapism, we must know very much. So immediately we have to put injection phenylephrine in the penis. You must immediately put injection phenylephrine into the penis. Phenylephrine or adrenaline should be injected so that the artery will go for spasm, so that no more blood will enter the penis. So phenylephrine or adrenaline should be injected in less than 36 hours. Within 36 hours, you must inject adrenaline or phenylephrine. That's more important. If it is more than 36 hours, it is very difficult to manage by injection methods. Such time we have to plan for shunt operations. What are the shunt operations? So please see the picture and drawing. So this is the penis. It is fully erected and painful now. So there are some shunt operations I will do now. I will put a shunt between corpora spongiosum and cavernosum like this. So this shunt which is done in the tip of the penis is known as distal shunt. Distal corporospongiosal shunt. Corpora spongiosum shunt. Known as winter shunt. The shunt will be done in the distal part. Similar shunt done in the proximal between corpus spongiosum and cavernosum is known as proximal corporospongiosum shunt. This is known as Satcher's shunt. Satcher shunt. So winter shunt is done at distal part of the penis. Proximally done as Satcher shunt. But the question asked in All India exam is, we cut one corpora cavernosa and we anastomose it with saphenous vein. So that is known as grey hat shunt. Grey hat shunt is asked in exam. It is corpora to saphenous vein shunt. I will show you this image also. So please don't forget winter shunt is done distally. Satcher shunt done proximally. And corpora with the saphenous vein is grey hat shunt. So please don't forget grey hat shunt. So this is about the priapism. Priapism injection should be given within 36 hours. If it extends beyond 36 hours, winter, satcher, grey hat should be done. Congenital, another one pathology I want you to tell here. Congenital posterior urethral wall. Congenital posterior urethral wall. One of the important causes of urinary obstruction. So one of the important cause of urinary outflow obstruction is congenital posterior urethral valve. It is common in boys. These guys present with inability to pass urine. When they pass urine, they'll have some difficulty, and this problem may be associated with vesicoureteric reflex also. May have associated vesicoureteric reflex also may be seen. So when you do a cystoscopy, the interesting point is when you do a cystoscopy and see the urethra, it will look normal. It will be normal. This can be diagnosed only by one investigation. Micturating cystourethropy will show you the. So I will show you this image also. This can be diagnosed very well only by micturating cystourethropy. So please don't forget this point. So this is congenital posturethral valve, which can be diagnosed only on micturating cystourethropy. So these are the important benign problems in penis. Finally, I am coming to the cancer penis, one of the common diseases in South India. Cancer penis. Why this is very important? Because this is common in age group of 40 years male. It is not a disease of old age. Please remember, it is seen in around age of 40 years men. It is commonly seen in age of 40 years men will get this cancer penis. 40 years men will get this cancer penis. So now, cancer penis is usually what type? Usually squamous cell cancer only. Other rare types of cancers are basal cell cancer, adeno cancer, melanoma, and Kaposi sarcoma in AIDS. All these are very rare types. So please remember, squamous cell cancer is the most common type. Please remember squamous cell. Please remember the most common type of cancer is squamous cell cancer. Other cancers are basal cell, adeno, malignant melanoma, Kaposi sarcoma in HIV patients. All these are also seen. But adenocarcinoma is one old MCQ. Where is adenocarcinoma seen? Adenocarcinoma seen arising from undersurface of gland penis from the Tyson's glands. From the Tyson's glands, adenocarcinoma can arise. Though it is very rare, just for completion, it can arise from undersurface from the Tyson's glands. You get adenocarcinoma. Okay. So please don't forget these points. Where are the cancers seen? And now you must know what are the common sites of cancer penis. The common sites of cancer penis. Please don't forget this is trapezial skin. This is trapezial skin. This is glans penis. This is shaft of penis. And this is corona glandis. Now at this point you should know the most common site of cancer penis. Where is the most common site of cancer penis? Common site of cancer penis is glans penis. Around 50% of the cases, cancer penis is seen here. In 20% of the cases, it is at trapezial skin. Trapezial skin in 20% of the skin. So most common is glans. Second common is trapeze. Second common is trapeze. So other places may be shaft, corona sulcus, all these are other places. So shaft, corona sulcus, anywhere you can get cancer penis, and mostly we see only squamous cell cancer of penis. So what are the predisposing conditions? That's a very important point you should know in cancer penis. What are the predisposing conditions we have already discussed? The most common predisposing condition I told you is smegma. So smegma is the most important predisposing condition you should not know. So that is why I told you circumcised people in Jews will have no risk of cancer penis. So because they never have smegma collected, so that is first point you should not forget. So other risk factors are, so smegma is one risk factor. Other risk factors are leukoplakia, balanitis xerotica obliterans, Buschke-Lowenstein tumor, which is a tumor like appearance from human papillomavirus, causing a tumor-like appearance. Buschke-Lowenstein tumor, BXO, leukoplakia are the important predisposing factors. Other things you should know here are carcinoma in situ arising from glands. What is it known as? Carcinoma in situ of glands is known as erythroplasia of Tourette. Carcinoma in situ from the shaft is known as Bowen's disease. So any skin also it is same, Bowen's disease. So carcinoma in situ of shaft of penis is Bowen's disease. Carcinoma in situ of shaft of penis is Bowen's, and then glands is erythroplasia of Tourette. Please don't forget this point. Very important. So these are the predisposing factors I want you to remember in cancer penis. And one type of cancer which is very rarely discussed is verrucous carcinoma. Verrucous cancer of penis is a variety of squamous cell cancer. It's a variety of squamous cell cancer. It is low malignant potential. It has low malignant potential. But the one interesting point here in verrucous carcinoma is it will grow aggressively on putting what? Aggressive growth will be seen on putting radiotherapy. So this is an interesting point in verrucous cancer. Though it has low malignant potential and low metastatic potential, there is an aggressive growth when you put radiotherapy. I will show you the image of a verrucous cancer. Where radiotherapy applied, the growth becomes very bulky and bigger. I will show you soon. Okay. So now, what are the clinical features of cancer penis? So you would have seen many cancer penis patients in your ward. The patients will have fungating growth from the shaft or somewhere in the penis will have fungating growth with a foul-smelling odor. The moment you see the patient coming, you will see a foul-smelling odor. Fungating growth with a foul odor is very classical feature. You can many times identify that is a cancer penis patient moving there because of the foul odor and fungating growth. The fungating growth having foul odor is usually due to secondary infection. Usually that ulcer or fungus fungating type of growth gets secondary infection and causes bad smell. Okay, that causes bad smell. And along with that ulcer growth and discharge, they present to you with the inguinal nodes. So the sentinel node of cancer penis, where is it? Sentinel node of cancer penis is known as cabana node. Sentinel node of penis is cabana node, which is nothing but superficial inguinal node. That is a superficial inguinal node known as cabana node. So patient presents with a fungating growth with a foul-smelling odor, and then inguinal node patient comes to you. So when you do clinical examination, we make a clinical staging in those days known as Jackson staging. It is no more used now. So there was a old simple staging, Jackson staging, in which stage 1 is involves glands or prepuce of penis. Very simple, very easy. But what to do? It is removed now. 2 is shaft, 3 is node positive, 4 is Mets positive. Simple staging, Jackson staging. Old staging of cancer penis is no more used. We are now using TNM staging. So TNM staging is based on size of the growth. T1 less than 2 centimeter. T2 2 to 5 centimeter. T3 more than 5 centimeter. Or it can invade the corpus spongiosum, or cavernosum, or urethra will be involved. Very interesting. So any local structure infiltration like corpus spongiosum, cavernosum, urethra. So if it is a penis, there is a cancer that is involving one muscle, corpus spongiosum, cavernosum, or going even up to the urethra. Usually urethra will not be involved because urethra has different epithelium, transitional cell epithelium. So usually urethra will not be involved by cancer penis, very rare, because they both have different epithelium. So and this point you should not forget. And P4 is involvement of adjacent structures like scrotum. That's gone to adjacent structures like scrotum being involved. All those things are adjacent structures. So involvement in adjacent structures. Okay. T1, T2, T3, T4. Don't forget this. And coming to N1. N1 is single node. Single lymph node enlargement is N1. N2 is multiple nodes enlarged. It may be unilateral or bilateral. All are inguinal nodes. Single inguinal node is L1. Multiple inguinal nodes, either unilateral or bilateral, is N2. N3 is deep inguinal nodes or iliac nodes is N3. The nodal mass is a major trouble in cancer penis because it is from this nodal mass causing erosion. The patient dies. Erosion of femoral artery happens. Erosion of femoral artery causes torrential bleed, causes severe bleeding, and many patients die because of this reason. Erosion of femoral artery causing bleeding is one of the most common cause of death in these cases. Cause of death in these patients is erosion of femoral vessel, because the node which is there in the inguinal region will grow bulky and it will erode the vessel and that will bleed like anything and the patient will die. Very difficult to control this type of bleeding, so please don't forget this. Coming to the management of cancer penis. So let us discuss first the management of primary of cancer penis. Primaries. Management of primary can be done by either radiotherapy or with surgery. Surgery is best method. Surgery is best method. But many times the people will not be ready for a surgery because they are very young males. They are not ready to lose the most important organ. So they may prepare radiotherapy like interstitial radiotherapy can be given. I'll show you the image. Interstitial brachytherapy. Or sometimes they use 5-fluorouracil cream for in situ cancers. Or they may even go for Mohs micrographic surgery. We will discuss about these things in skin cancer chapter. Mohs micrographic surgery, in which the cancer is sliced slowly. It's an organ preserving areas. We do Mohs micrographic surgery. So interstitial brachytherapy, 5-fluorouracil cream, Mohs micrographic surgery, or laser excision, or various other methods of treatment. But surgery is overall the best method. What will you do in surgery? I'm going to discuss. So please understand, in surgery you should understand one basic concept. This is a penis. This is the root of penis. So if there is a cancer in the penis tip, how many margin you must give and cut the penis? Can you tell me? You must give 2 centimeter margin and cut the penis. When you give 2 centimeter margin and cut, how much shaft should be remaining? The shaft should remain as 2 centimeter. Then only he can pass urine in standing position and he can have sexual activities. For having a normal sex and passing urine in standing position, a male needs at least 2 centimeter of penis. So therefore, the surgical treatment done for cancer penis involving glands, prepuce and all is partial penectomy. It is known as partial penectomy will be done. So usually we prefer to do partial penectomy. So when will you do total amputation of penis? The point is, when will you do total amputation? When you cannot have 2 centimeter, when you cannot preserve 2 centimeter, we have to go for total amputation of penis. The cases we should go for total amputation of penis is indicated when there is less than 2 centimeter shaft after clearance. After clearance, the remaining shaft is less than 2 centimeter. When the urethra is involved, urethral involvement present. Okay, when the urethral involvement is present, or when the shaft is less than 2 centimeter after resection, in these cases we have to go for total amputation of penis. Some interesting names in those days: Young's operation. What do you mean by Young's operation for cancer penis? Means it is partial penectomy operation plus bilateral ilio-inguinal dissection. So this is Young's operation. Partial penectomy with removal of both side nodes is known as Young's operation. What is Piercy Gold operation? It is not done nowadays. Piercy Gold operation. These are all old names. Just for completion, I'm telling. Piercy Gold operation is an operation in which, along with the total amputation, scrotum is also removed. Total amputation of penis plus scrotum also is removed. That is known as emasculation. Emasculation, removal of penis, scrotum, everything. That area will be totally removed. That is Piercy Gold operation. So Piercy Gold operation is total emasculation operation. Nobody does that. We should not remove the scrotum and testis unless there is direct involvement by the growth. Unless the cancer penis directly involves the testis or scrotum, we should not remove the testis, because they are young males. Testis is very important for their long-term testosterone production and masculinity and skeletal growth. For skeletal growth and masculinity, they need testis. So don't remove testis unwantedly. In those days, the old surgeons will tell, what they will tell is, if this is a patient coming to them like this, having a cancer here like this, the patient comes to them with a cancer like this, they used to tell, why should you leave the testis when there is no penis? They used to tell, what is the use of bullets without gun? Remove everything. Like that they used to remove those days. What is the use of bullets without gun? And they used to remove everything. They do emasculation. That should not be done hereafter. Such type of phrases we never hear in operation theatre today, because the surgeons realize the importance of testis. So testis is essential for masculinity, skeleton development. So we don't do that removal. So that is the treatment of primary. Either by brachytherapy or by surgery, we should treat the primary. Now what about the secondaries? So if there is already a palpable node present like this, if there is already palpable node is positive, FNAC showing it is malignancy, node positive cases, the treatment is very simple. We make a lazy S incision like this. And we do ilio-inguinal block dissection. So we do a ilio-inguinal block dissection by making a lazy S incision like this. So if node is positive, please remember, if node is positive, we make a lazy S incision, remove all the nodes in the inguinal area, superficial inguinal nodes, deep inguinal nodes, even the iliac nodes will be removed. So this is the treatment if node is positive. The patient comes to you with node negative. There is no node. We cannot send them home just like that. We have to know whether there is any non-palpable or micromex present. So initially they were doing sentinel node biopsy of Cabana. In those days, like sentinel node biopsy of Giuliano of a cancer breast. So this is sentinel node biopsy of Cabana was done in those days. So it is the first node from cancer penis. First node from cancer penis is known as sentinel node of Cabana. They used to do in those days, but it is totally abandoned now because we don't know where is going to be the first node. So therefore, people afterwards modified into superficial inguinal dissection for all patients. For all cancer penis patients, they used to do superficial inguinal dissection of Dassler was done. They used to remove all the superficial inguinal nodes, send it for histopathological examination. As usual, if it is positive, we do ilio-inguinal block dissection. So this is what done for some period of time. But what is the latest protocol? latest protocol for N0 cases is the following. So we do a modified ilioinguinal dissection of Catalona. Modified ilioinguinal dissection of Catalona was done. Modified ilioinguinal dissection of Catalona, in which we remove both superficial group as well as deep group is removed. Some amount of nodes, not all the nodes. In a small rectangular area, superficial and deep nodes all are removed and sent for histopathological examination. If it is positive, then we do ilioinguinal block dissection. So I want you to tell here certain protocol. So what is the treatment of cancer penis? So cancer penis, the treatment is either partial penectomy or total amputation. One of these two is done. Partial penectomy or total amputation is done. After removing them, after removing the primary, we have to see for nodes. If nodes are positive, there is no further discussion. Ilioinguinal block dissection will be done. If nodes are negative, there are many protocols done like sentinel node biopsy of Cabana, superficial dissection of Dassler, but the latest is modified ilioinguinal dissection of Catalona. And if it is showing any positive nodes, what you will do? If there is a positive node, we should do ilioinguinal block dissection. If it is showing negative, no further treatment. No further treatment if it is negative. This is the protocol in cancer penis management. The cancer penis management, what is the protocol? Please don't forget this protocol. So cancer penis, I will show you all these images now so that you will understand the discussion. So we have now discussed the important topic on urethra and penis. So this is the typical hypospadias. As you can see, what I am holding here is dorsal hood. And you can see the ventral opening, and this is ventral chordae. So this is the typical hypospadias, 1 and 250 people. So ideal time is 6 months to 12 months. Okay. And don't forget, MACP is the latest procedure previously done. Dennis Brown is no more done. Metal advancement glanoplasty incorporation. Phimosis, I told you, phimosis. This is a typical surgery done for small children. This is plastible device. Image-based question from Bailey and Love, plastible or polyester device is used for circumcision. So this is a condition I told you, paraphimosis. We have to put multiple puncture all places and reduce it. If it is not coming out, we have to do dorsal slit now and later plan for circumcision. You can see the dorsal curvature. This is what I told you, dorsal curvature of the penis. The penis will turn upwards. Dorsal curvature with the seen on X-ray. Peyronie's this is. So we have to do the operation known as Nesbitt procedure. So this is a typical priapism. You can see the penis is looking, venous ganglion is coming. So this is a typical low flow priapism seen in sickle cell anemia, leukemia, and lymphoma. Urgent treatment needed. We have to immediately inject adrenaline in the penis. This is the god priapus from internet. You can see his penis, such a very big penis you have. So that is why the name has been given as priapism from this god. And you can see the winter shunt being done between the glans penis and corpora cavernosa. We make a winter shunt. Distal shunt is winter, proximal shunt is stature, and great act is corporos sepinus shunt. Okay. So this is the great action. Sepinus vein is anastomosed to corpora cavernosa known as great action. So this is a micturating cystourethrogram showing you a posterior urethral wall. Congenital posterior urethral wall, investigation of choice is micturating cystourethrogram. It will look normal on a cystoscopy because when you pass from this side, the wall will open backwards and it will not be seen at all. So in a cystoscopy, it will look normal. But in a micturating cystourethrogram, you can identify this wall which acts like a flat wall. So typical cancer penis, you can see the most common site is glans penis. And these are the various malignancies in the prepuce. You can see typical Buschke-Lowenstein type of tumor due to human papillomavirus. And this is erythroplasia obturate carcinoma in situ of glans penis. And this is verrucous carcinoma which has grown very aggressively after radiotherapy. So radiotherapy should not be given. So radiotherapy is contraindicated in verrucous. So various staging and staging. See, you can see the verrucous cancer we have done a clearance, 2 cm and a partial amputation. So this cancer now you are going to see partial amputation. See the image of partial amputation going on. Cut, and you can see the completed operation. So this is the total amputation. Where is the urethra now? Where is the urethra? It is on the undersurface of scrotum. Perineal urethrostomy is done. Okay, perineal urethrostomy is done. So ilioinguinal block dissection operation going on. All the nodes in the inguinal region, iliac region is removed. And you can see the external iliac artery and external iliac vein exposed. We have to use sartorius muscle to close that artery and vein now. So that is closed and the incision is completed. It is the penis. You can see the picture of penis with a brachytherapy going on. Penis full of needles, brachytherapy going on. It is a very important topic, cancer penis. So please remember, especially for final year students, you can get questions from cancer penis. Please don't forget the N0 cases. We don't send them home. For no node palpable in the inguinal region, we should either do olden days sentinel node biopsy, superficial inguinal dissection of Dassler. Now we are doing superficial ilioinguinal dissection of modified ilioinguinal dissection of Catalona is being done now. And any node is positive in that, we have to reopen and do ilioinguinal block dissection. So cancer penis is a very important topic for your